Hi, it's Lauren Tucker, and it's January 7th, 2020, and this is my Unit 4 Case Connections presentation. Case 1 describes a newborn girl who develops lethargy, hypothermia, and apnea within the first 24 hours of life. The doctor suspects a metabolic disturbance. Which of the following tests would be best to distinguish between a disorder of the urea cycle and beta oxidation? Blood glucose, urinary acids, serum fatty acids, or plasma glutamine? Let's go over the incorrect answers first. Blood glucose levels would be able to determine if there may be an issue with beta oxidation. Defects in the beta oxidation pathway, like any fasted state condition, will cause glucose levels to be lower than normal. Because hypoglycemia is not a test specific to beta oxidation deficiencies and is not a tool used in assessing for urea cycle disorders, this answer is incorrect. Analyzing serum fatty acids can be a useful tool in assessing for beta oxidation disorders. However, abnormal levels can also be indicative of other conditions, such as paroxysmal disorders, as well as dietary deficiencies or excess. And since this test does not help when looking at urea cycle disorders, this answer is also incorrect. Though plasma glutamine levels can determine if there is a defect in the urea cycle, they can also be helpful in assessing acute and chronic liver failure. Furthermore, an elevated plasma glutamine level can be a sign of a urea cycle disorder, but blood ammonia levels must also be taken into account for proper diagnosis. Therefore, this answer is incorrect. That leaves us with urinary acids. Several types of urinary acids can help play a role in distinguishing many metabolic disorders. Issues with beta oxidation can result in both an increase and decrease of ketones in the urine. However, increased ketone bodies may also indicate diabetic ketoacidosis. On the other hand, an increase or decrease in orotic acid in the urine is a specific indicator of a urea cycle disorder. Thus, if we test for orotate in the urine, we can distinguish between a beta oxidation disorder and a urea cycle disorder. Diagnostic analysis shows elevated blood ammonia, markedly elevated urine orotate, and normal plasma citrulline. Given this further information, it is clear that this newborn has inherited a urea cycle disorder. One urea cycle enzyme that is likely deficient in this case is ornithine transcarbamylase, or OTC. Like all urea cycle disorders, OTC deficiency causes hyperammonemia. It also causes severe orotic aciduria. Citrulline levels will usually be decreased as OTC catalyzes a reaction between carbamoyl phosphate and ornithine to yield citrulline. Despite the case study describing the citrulline level as normal at 10, the normal reference noted is 12 to 55, so let's actually consider this value low in this scenario. One urea cycle enzyme that is least likely to be impaired is argininosuccinate synthetase. Deficiency of this enzyme known as citrullinemia type 1, like all urea cycle disorders, again will cause hyperammonemia. Much like the name suggests, however, it also causes an increase in plasma citrulline levels due to a block in the urea cycle where argininosuccinate synthetase catalyzes a reaction between citrulline and aspartate to yield argininosuccinate. Furthermore, orotic aciduria is not associated with this deficiency. In case 3, a 47-year-old man is complaining of right-grade toe pain that is so severe he is unable to bear weight on it. There are no obvious signs of trauma. The pain began yesterday and is worsening. After a full investigation, this patient is diagnosed with gout. His lab work reflects elevated plasma urate and decreased urinary acid excretion. What is the best explanation for this patient's gout? Overproduction of purines, decreased salvage of purines, or decreased urinary excretion of uric acid? Firstly, all of these answers are associated with hyperuricemia and gout. Overproduction of purines is a cause of gout associated with von Gierke disease, or glycogen storage disease. This is due to a deficiency in glucose-6-phosphatase. This prevents the proper utilization and storage of glycogen. The condition results in fasting hypoglycemia and hepatomegaly. Because glycogen cannot be used in glycogenolysis, we see a diversion to glycolysis, fatty acid synthesis, and, of relevance, the pentose phosphate pathway. Diversion into the pentose phosphate pathway results in a flood of ribose 5-phosphate. This excess ribose 5-phosphate activates 5-phosphorybosyl-1 pyrophosphate, or PRPP, synthetase, and results in an excess production of both purines and pyrimidines. But pyrimidines can be further metabolized and utilized in other pathways as they typically do. The purines will also move forward as usual, and the excess purine nucleotides are catabolized, resulting in an excess of uric acid production. This answer is unlikely, but possible. Decreased salvage of purines is linked to Lesch-Nyhan disease. This disease is caused by a mutation in hypoxanthine guanine phosphoribosyltransferase transferase, or HPRT, and is associated with several other conditions aside from gout, including neurological and renal issues. Those affected are often non-ambulatory, and this condition is diagnosed early in life. Lesch-Nyhan disease is also associated with an excretion of uric acid, which contradicts the given lab work. Therefore, this answer is incorrect. Decreased urinary excretion of uric acid is evident on the labs shown. This is likely caused by inhibition of the urate transporter in kidneys from lactate, succinate, beta-hydroxybutyrate, or acetoacetate. Most commonly, metabolism of ethanol leads to a buildup of lactate and thus a buildup of uric acid, as lactate inhibits urate excretion. This may be the cause of this patient's gout. Further evaluation is needed to determine the root cause of this patient's gout, including an assessment of his routine alcohol intake, dietary habits, genetic testing, and perhaps a liver ultrasound. Ultrasound of the liver can assess for hepatomegaly and fatty liver, which can help further evaluate for von Gierke disease. There are 3 known genetic causes of primary gout, including glucose 6-phosphatase deficiency, HPRT deficiency, and elevated PRPP synthetase activity. We've already discussed HPRT deficiency and glucose 6-phosphatase deficiency, but I do want to note that glucose 6-phosphatase deficiency leads to elevated PRPP synthetase activity, but increased PRPP synthetase activity can also be present on its own. Upon further discussion with this patient, he says he's been drinking 4 to 5 liters of soda a day. Increased fructose in the diet can cause gout flares. Fructose encourages uric acid production through a depletion of ATP, as seen in AMP production, and decreased urate excretion, and from supplying amino substrates such as glycine. Referred to as the king's disease, gout has always been thought to be caused by diet alone. It is now more understood that genetic predispositions, as previously discussed, also play a role. A long-term diet rich in purines and low in dairy has been shown to encourage the formation of gout. With proper medication and dietary modification, however, gout is a lifelong but manageable disease.